As far as aspirin resistance is concerned, again, we've got a real mess out there in terms of standardization, understanding what all these methods actually mean. We have no consensus on this. The correlation between different methods of measuring it is not great. The PFA 100 in particular, I think what we're measuring in a lot of patients is increased von Willebrand factor. But again, since increased von Willebrand factor has been shown to be an independent risk factor for increased events in these patient populations, we're just seeing this. We're calling it aspirin resistant, but it may just be a surrogate marker for inflammation, which may nevertheless be associated with enhanced risk. So overall, most of these methods do correlate somewhat with clinical outcome. Even if we're not measuring aspirin resistance per se, we may be measuring something which at least is a good marker for risk. And we have, at this time, a real lack of consensus about how to measure it, what to do with the results, and how to manage the patients that we classify as aspirin resistant. We do have a couple of ongoing studies, however, which I think are going to be very informative in answering some of these questions. And if you like acronyms in clinical trials, here's a couple of great examples. We have ASCE or ASCET, which is aspirin non-responsiveness and clopidogrel endpoint trial. And my favorite, resistor. There must be panels of people who sit around and think of this stuff. It's research evaluation in study individuals who show thromboxane or P2Y12 receptor resistance. I mean, you would never think of that on your own, would you? It has to be a committee. So with that, I will stop. I'll be happy to take your questions, and I appreciate your attention. No. Good question, but I don't think so. No. Yeah.
What about dose response in terms of aspirin resistance? Is there a threshold that you can overcome?
I think for a lot of patients, the question was, is there a threshold in terms of dose response that will overcome apparent resistance? And yes, in a lot of studies, simply increasing, say, from 81 milligrams to 325 produces the expected outcome in whatever laboratory test that you're using. So I think from a certain perspective, that's absolutely true. Just increasing the dose overcomes that. Again, having said that, the caveat is there still really aspirin resistance, or is it just you've got another route of platelet activation that can be overcome maybe by adding more aspirin into the mix? And until there's clinical trial data that show that outcomes are restored to expected levels, or the risk is reduced back to expected levels if you make that change in dose, and those data are not here yet. But certainly from a laboratory perspective, yes, you can often overcome it with increased dose. Yeah.
For patients who are aspirin resistant, how much is there a crossover for those patients to then be Plavix resistant?
Well, that's a great question. How many of the aspirin-resistant patients are also Plavix resistant? And I haven't actually seen any data on that. There are certainly some patients that are apparently resistant to both. But again, I question the fact whether this is true resistance or whether you've got, a powerful avenue for platelet activation coming through some other route, which is just too powerful for even the combined drug therapy to overcome. The answer is, some of the clinical trials that are ongoing are going to address these issues. Ken.
A lot of people are taking 81 milligrams of aspirin, also taking statins.
Right.
So how do these compounds?
Again, I don't think anybody's really looked at that. I mean, that's true. A lot of patients are taking statins as well as their baby aspirins, and whether that impacts the apparent aspirin resistance to some of these laboratory methods. We just don't know. Would not be surprising if that was true.
The same data on this for agronauts and things like that.
I'm sorry?
You have the same type of studies where you've got combined aspirin and clopidogrel in all these little machines.
Yeah, I don't think I'm understanding what your question is there.
In other words, you've got Plavix or aspirin, you've got Agronox, which is a combination of aspirin and a different inhibitor.
Right.
You have similar studies with the different platelet function machines that show there is or isn't resistance to that.
I don't think there are any studies that show that. I don't think that's been addressed. Good point. As you can tell, this is an area where there's an awful lot of studies ongoing right now. This is why we're kind of standing here in this kind of limbo, really not knowing which direction to go. And I, for one, in my laboratory, ceased doing aspirin resistance tests about a year ago, because I was seeing so many of the patients were coming up as aspirin resistant, and physicians would call me up and say, okay, now what do I do? And I say, I haven't got a clue. I have no idea what to tell you. And if I can't tell the physician or give them any advice, either from my experience or from the literature, as what to do with the results of the laboratory test, and I think I shouldn't be doing the laboratory test. So we stopped. Yeah?
Are there any of the over-the-counter or homeopathic remedies that patients are taking now to interfere with these tests?
Well, that's a great question, because we don't know. But a lot of the time, what a lot of these over-the-counter homeopathic, naturopathic, type medications do to platelets. We know that a lot of them do affect platelet function. We know, we can see prolonged bleeding times or prolonged PFA, and all the patient's been on is, X, Y, and Z, type of thing from the health food store. We have no clue right now as to whether or not the concomitant ingestion of those kind of medications or those kind of agents with aspirin or with clopidogrel can mask the effect or enhance the effect or what. Again, no studies. Okay, thank you very much.